Welcome to our weekly medical coding scenario on completion thyroidectomy. Today we'll simplify this important medical procedure, ensuring you understand the essentials of coding and surgery involved. A completion thyroidectomy is performed after a previous lobectomy. In this case, our patient had a painful history with multifocal papillary thyroid carcinoma. Initially diagnosed with a left dominant nodule, she underwent a left thyroid lobectomy. During follow-up, doctors found residual cancer requiring further action. Before surgery, all potential risks were shared with her. These include anesthesia complications, bleeding, infection, and possible long-term effects like vocal cord damage. The patient weighed these risks and opted for the procedure. In the operating room, general anesthesia was administered. First, the medical team ensured the airway was secured with a nerve integrity monitoring tube. They positioned the patient correctly, preparing for surgery. The previous incision was reopened. They carefully excised any old scar tissue. This step is vital to ensure a clean entry point and to recognize anatomical landmarks. Next, they raised the skin flaps and isolated the strap muscles. The surgery involved careful dissection to preserve critical structures like the parathyroid glands and the recurrent laryngeal nerve. This attention to detail safeguards the patient's voice and calcium levels post-surgery. During the procedure, multiple lymph nodes in the paratracheal area were also removed. These lymph nodes were dissected with precision and sent for analysis, as they play a crucial role in cancer staging. After the completion of the surgery, the wound was irrigated, and hemostasis was achieved before closing the incision. The patient was extubated and transferred to the recovery unit in stable condition. Now let's discuss coding. The primary procedure is reported using CPT code 60260RT. This reflects the removal of all remaining thyroid tissue after lobectomy. The lymph node removal is coded as 38510RT, indicating open excision of right paratracheal nodes. Modifiers are crucial for proper billing. Remember that the lymph node excision can sometimes be bundled with the thyroid procedure, depending on payer guidelines. Always check NCCI edits to confirm if you need to append modifier 59, indicating a distinct surgical effort. For diagnosis, we use ICD code C73 for malignant neoplasm of the thyroid. It's essential to document carefully, as not all findings, like lymph node metastasis, can be assumed without verification. In summary, completion thyroidectomy includes removing the remaining lobe and relevant lymph nodes. Use patient history to guide coding accurately, ensuring that surgeries performed are documented correctly. If you're a coder or healthcare professional, mastering these concepts is crucial. Keep reviewing guidelines and stay updated with best practices to ensure optimal patient care and accurate billing. Follow Coding Clarified for more Thursday coding scenarios. Thanks for watching.